So I think that technical glitch has been solved. Thank you. So that we can continue now with our lecture. You can call it anything. You can call it sure shot INICET or INICET PYQs. But a few things remain the same. So I was talking about how is INICET different. Well, you know, all these entrance exams, whether it is INICET or whether it is NEET PG or anything, you know, they are all going to check your knowledge. I mean, what you have been doing in last 1, 2, 3, 4, 5 years of your preparation. Okay, means I'm going to say from the first year itself. But then there can be some things which are different for different exams and how you can prepare for last minute. So for INICET, in the last few days, last week or last month, what you should go for is more of concepts, because I've seen over the years that lots of conceptual MCQs are asked in the INICET exams. Concept based, equation based, formula based MCQs, image based MCQs, graph based MCQs. So you can have more attention to these in last 1 month or last 1 week or so. So that's my first point, how INICET is different. Otherwise, any exam will check only your knowledge and how you figure out the answers. That's one. Second point is what are the do's and don'ts in last 1 month or last week or last minute preparation. I just have to say two things in this. I can still not see the messages. Okay, so anyways, if anybody is watching, can just show a thumbs up so that I can I would know that messages are being sent. Okay, yeah, so I was coming to that point where last month preparation, last week preparation, and last few days preparation. I've made a video on this, do's and don'ts in last month, last week. So just two things I'll mention here and then we will proceed further. One thing that is, don't solve too many MCQs in the last stage of your preparation. I know that this is something different from what others might be telling you. Most of the times people tell you that solve as many MCQs as possible. No, I have a different take on this. Now, first of all this is a game of neurophysiology, and all this is a game of neurotransmitters and synapses and neurons, okay, where the information is stored for you. So remember this, when you solve the MCQs, you also look at 3 wrong options along with 1 correct option. And many students who have appeared for these exams and they came out of the exams cribbing, saying that they knew the answer and yet they marked wrong answer because they had retained some wrong answer from their solving preparation, you know. So therefore, it's not a good idea if you are into the last week or last month of preparation. It's not a good idea to solve, to have very heavy MCQ solving. वो अच्छी बात नहीं होगी. आप जनरल थोड़े से MCQ सॉल्व कर सकते हो, लेकिन उससे ज़्यादा बहुत सॉल्व ना करे तो बेहतर होगा. ओके, टॉपिक्स देख लो और एक्सप्लेनेशंस पढ़ लो. ओके, एक्सप्लेनेशंस पढ़ लो MCQs के बाद, दैट विल बी गुड इनफ. लेकिन बहुत ज़्यादा हेवी MCQ सॉल्विंग अवॉइड करना. ओके, नहीं तो रॉन्ग ऑप्शंस रिटेन करने के चांसेस होते हैं। तो ये एक है बहुत इंपॉर्टेंट पार्ट। और दूसरा, अभी सपोज 6-7 दिन बचे हुए हैं, 10 दिन, जितने भी दिन बचते हैं, लास्ट मिनट प्रिपरेशन है, तो आपका सर्कैडियन रिदम आप सेट करने की कोशिश करो। ओके, इसकी रीज़न ये कि आप अभी दिन रात पढ़ रहे हो, रात को जागते होंगे और 4 बजे सो के फिर 10 बजे उठ के प्रिपरेशन, ऐसा कुछ आपका सर्कैडियन रिदम रहा होगा। लेकिन एग्जाम डे पे यू नीड टू बी एट द टॉप ऑफ योर गेम, और उसके लिए ज़रूरी है कि आपका सर्कैडियन रिदम अच्छे से सेट हो। तो 7 दिन 10 दिन बचे हुए अगर एग्ज़ाम को, तो ये लास्ट फ्यू डेज़ में आपको आपका बायोलॉजिकल क्लॉक प्रॉपरली सेट करना होगा। ओके, थोड़ा जल्दी सोना शुरू करो। अभी 4 बजे तक जाग रहे हो तो फिर 3, 2, 1, तो थोड़ा प्रॉपर रहेगा। एग्ज़ाम डे पे आपके न्यूरोट्रांसमिटर्स का फ्लो, आपके साइनेप्टिक ट्रांसमिशन का फ्लो एकदम अनहिंडर्ड, स्मूथ और एकदम ज़बरदस्त मक्खन की तरह होना चाहिए। ओके, इसलिए ये ज़रूरी है। और हाई कार्ब डाइट वगैरह अवॉइड करो। मेरा वीडियो बाद में देख लेना आप कि क्या क्या अवॉइड कर सकते हो इन द डाइट और डूज एंड डोंट्स। एंड और एक हिंट देना चाहूँगा, और उसके बाद हम एक्चुअली वी विल स्टार्ट विथ आवर डिस्कशन ऑन एमसीक्यूज। वो ये है कि आप जब पेपर सॉल्व कर रहे हो, चाहे INICET एग्ज़ाम में हो या किसी भी एग्ज़ाम के लिए लागू होता है, लेकिन खास करके INICET के लिए मैं बता रहा हूँ, that when you see the question, don't immediately look at the options. Okay, या थोड़ा स्पेलिंग करेक्ट कर लेना। इमीडिएटली डोंट लुक एट दी ऑप्शंस। बहुत सारे स्टूडेंट्स को ये आदत होती है कि भाई क्वेश्चन पढ़ते हैं, फिर ऑप्शंस पढ़ते हैं और उसमें फिर करेक्ट आंसर ढूंढने की कोशिश करते हैं। खास करके INICET के लिए आपको ये अवॉइड करना होगा। अवॉइड दिस, एंड द रीजन इज दैट के आप देखो, ये कॉन्सेप्ट बेस्ड एग्जाम होने वाली है INICET, तो आपकी अगर कॉन्सेप्ट स्ट्रांग है तो क्वेश्चन पढ़ने के बाद तुरंत आपको आंसर, तो अगर आपने वो टॉपिक प्रिपेयर किया तो आंसर आ जाएगा। ओके, और इसलिए ऑप्शंस देख के और कंफ्यूजन बढ़ाने से अच्छा है कि पहले ही उसको कवर करो, ऑप्शंस को, क्वेश्चन पढ़ो और उसके बाद आंसर मन में लाओ, क्या आंसर हो सकता है, उसके बाद ऑप्शंस देखो। अगर तो आपका आंसर उस ऑप्शंस में है, इसका मतलब कि आप सही जा रहे हो, उसको टिक करो एंड दैट्स ऑल, आपने करेक्ट आंसर मार्क कर लिया है। अगर नहीं ही पता है कुछ टॉपिक का, तो आप ऑप्शंस देख सकते हो। ओके, और ट्राई टू फिगर आउट, ट्राई टू मतलब सॉल्व दैट MCQ। तो ये मेरे कुछ डूज एंड डोंट्स है, नुस्खे। एंड नाउ कमिंग टू दी फिजियोलॉजी टॉपिक, फिजियोलॉजी एज अ सब्जेक्ट, क्योंकि ओके, फिर से थोड़ा सा फ्रीज हो गया है, बट कोई बात नहीं, आई ट्राई टू फिगर आउट। हाँ, तो ये कि फिजियोलॉजी क्या लास्ट मिनट प्रिपरेशन कैसे होना चाहिए आखिरी 8-10 दिनों में। नाउ लुक, द थिंग इज कि फिजियोलॉजी सब्जेक्ट के साथ हमेशा एक दिक्कत रही है। मैं हमेशा स्टूडेंट्स जब एग्ज़ाम से बाहर निकलते हैं तो मैं एग्ज़ाम सेंटर्स में जाता हूँ, तो और काफ़ी स्टूडेंट्स को पूछता भी हूँ कैसे गया एग्ज़ाम, एंड यू नो क्या क्या फिजियो के MCQs क्या थे एंड ऑल। वो फिजियो के MCQs रिकॉल भी नहीं कर पाते ठीक से। उसकी वजह यह है कि फिजियो हर एक सब्जेक्ट में आता है ना। अरे भाई, एक ऑप्थेल्म का MCQ भी फिजियो बेस्ड हो सकता है, इंट्राऑक्यूलर प्रेशर या समथिंग। एक एनास्थीसिया का MCQ भी फिजियो से रिलेटेड हो सकता है, CSF प्रेशर इन द लाइंग डाउन पोस्चर या समथिंग। हर एक सब्जेक्ट में फिजियोलॉजी का है कुछ ना कुछ, और इसलिए मानने को तैयार होते नहीं कि वो फिजियो का MCQ होता है। फिजियो का MCQ कौन सा था, तो ठीक से उनको याद भी नहीं आता। ये एक दिक्कत रही है हमेशा, और बाकी सारे फैकल्टीज़ भी क्लेम करते हैं ये तो हमारे सब्जेक्ट का था, ये तो हमारे सब्जेक्ट का था, और इसलिए फिजियो ऐसा प्रॉपर कोर फिजियो, ऐसे MCQs याद भी नहीं आते बच्चों को कई बार। खैर कोई बात नहीं, फिर भी हम ये करते हैं। लेकिन फिर भी अगर आपको बाकी सारे सब्जेक्ट्स में भी अच्छा करना है, तो फिजियो की कौन सी सिस्टम्स लेके आपको ये लास्ट 6 दिनों में, 7 दिनों डेज में, 10 दिनों में प्रिपेयर करनी है। तो हाँ, बेसिकली आपको ये 5 या 6 सिस्टम्स करनी होगी प्रॉपरली, ओके। जैसे कि जनरल फिजियो, नर्व मसल, CVS, RS, CNS और किडनी, ये 6 सिस्टम्स पे आपको फोकस करना होगा। क्यों ये 6 सिस्टम्स कह रहा हूँ मैं? क्योंकि बाकी सारे सिस्टम्स ना आप अपने जनरल नॉलेज पे भी सॉल्व कर सकते हो एमसीक्यूज। एंडोक्राइन तो इतना आपने किया होगा, रटा होगा इतने सालों में कि उसका एमसीक्यू का आंसर आ ही जाता है प्रॉपरली। या ब्लड के बहुत जनरल नॉलेज बेस्ड एमसीक्यूज होते हैं ब्लड के। लेकिन ये 6 सिस्टम्स में से फर्स्ट 3 सिस्टम्स है ना, उसमें कोर फिजियो के एमसीक्यूज आते हैं, जनरल फिजियो, नर्व मसल, और उसके बाद CVS, RS, CNS और किडनी, ये 4 सिस्टम्स बहुत सारा क्लिनिकल एप्लीकेशन आता है। तो पहली 2 सिस्टम्स आप कोर फिजियो एमसीक्यूज, और आखिरी 4 सिस्टम्स जो बताई मैंने, CVS, RS, CNS और अपना किडनी, इनको आप फिजियो और उसके बाद उसका अप्लाइड फार्मैक में, पैथो में, मेडिसिन में इस तरीके से अप्लाई करने की कोशिश करो आखिरी फ्यू डेज में। तो आपका बहुत अच्छा सारा कॉन्सेप्ट बेस्ड प्रिपरेशन हो जाएगा फॉर द एग्जाम। तो ये सारी चीज़ें मैं आपको बताना चाह रहा था। एंड विद दैट इन माइंड, लेट्स नाउ स्टार्ट हैविंग अ लुक एट द MCQs विच आई हैव टेकन, सिलेक्टेड फॉर दिस पर्टिकुलर डिस्कशन। तो चलिए स्टार्ट करते हैं। पहला MCQ है, अच्छा ये MCQs मैंने इसलिए सिलेक्ट किए क्योंकि मैं एक्सपेक्ट कर रहा हूँ कि इस बार INICET में इन टॉपिक्स से MCQs आएंगे, ऐसा एक एक्सपेक्टेशन है, मेरा एक्सपेक्टेशन है, ओके। तो इंक्रीज्ड कॉन्सेंट्रेशन इन द ट्यूब्यूल्स इज सीन फॉर विच ऑफ द फॉलोइंग, ओके। द फर्स्ट थिंग इज के इसको एक और टर्म भी यूज की गई है और वो है TF to P रेशियो। तो ऑल राइट, it's called tubular fluid to plasma concentration ratio. TF to P ratio will be high for which of the following, ऐसा भी पूछा जाता है। तो बहुत आसान है गेस करना। अगर ट्यूबुलर फ्लूइड में किसी का कॉन्सेंट्रेशन बढ़ रहा है अलोंग द नेफ्रॉन, यानी PCT, लूप ऑफ हेनले, DCT, कलेक्टिंग डक्ट, अगर ये कॉन्सेंट्रेशन बढ़ रहा है ट्यूबुलर फ्लूइड्स में, तो ऑब्वियसली ट्यूबुलर फ्लूइड्स में दैट सब्सटेंस मस्ट बी सिक्रीटेड, है ना, तभी तो ट्यूबुलर फ्लूइड्स में उसका कॉन्सेंट्रेशन बढ़ेगा एंड देयरफॉर दिस रेशियो विल गो ऑन इंक्रीजिंग फॉर दैट पर्टिकुलर सब्सटेंस। और जबकि जो सब्सटेंस रीएब्सॉर्ब हो रहा है फ्रॉम द वेरियस सेगमेंट्स ऑफ द नेफ्रॉन लाइक PCT, लूप ऑफ हेनले, इनमें से अगर रीएब्सॉर्ब हो रहा है कोई सब्सटेंस, तो उसका TF to P रेशियो विल गो ऑन डिक्रीजिंग, क्योंकि ट्यूबुलर फ्लूइड्स में उसका कॉन्सेंट्रेशन जो है वो कम होता जाएगा बिकॉज इट इज गेटिंग रीएब्सॉर्ब्ड फ्रॉम द ट्यूबुलर फ्लूइड्स, है ना। तो ऐसे अगर ये आपको पता है देन द आंसर विल बी ऑब्वियस। अमाइनो एसिड्स, नाउ लुक, 100% अमाइनो एसिड एब्सॉर्प्शन, रीएब्सॉर्प्शन ऑकर्स फ्रॉम द PCT, तो ट्यूबुलर फ्लूइड्स में उसका कॉन्सेंट्रेशन बहुत कम रहने वाला है। पूछा क्या है, इंक्रीज्ड कॉन्सेंट्रेशन इन द ट्यूब्यूल्स, इंक्रीज्ड कॉन्सेंट्रेशन इन द ट्यूबुलर फ्लूइड्स, इसका मतलब ये सब्सटेंस सिक्रीट होने वाला है, ना कि रीएब्सॉर्ब होने वाला। ग्लूकोज, ऑलमोस्ट 100% ग्लूकोज इज रीएब्सॉर्ब फ्रॉम द PCT, तो इसका भी ट्यूबुलर फ्लूइड्स में कॉन्सेंट्रेशन कम होने वाला है। क्लोराइड, 70 to 75% क्लोराइड, फिल्टर्ड क्लोराइड इज रीएब्सॉर्ब्ड फ्रॉम द PCT, तो इसका भी ट्यूबुलर फ्लूइड्स में कॉन्सेंट्रेशन कम होगा। तो बचा कौन सा, बाइकार्बोनेट। यस, बाइकार्बोनेट जो है फिल्टर तो होता है, उसके अलावा बाइकार्बोनेट ऑल्सो गेट्स सिक्रीटेड in the segments of the nephron, particularly in the collecting duct, okay, there is bicarbonate secretion and therefore its concentration in the tubules will be increased and tubular fluid to plasma concentration or tubular fluid to plasma ratio will also increased for bicarbonate. So answer is D. जैसा कि आप देख सकते हो यहाँ पे. Okay. चलिए तो आगे बढ़ते हैं और देखते हैं अगला एमसीक्यू. यस, तो एक्सप्लेनेशन भी मैंने यहां लिख के रखा है क्योंकि लिखने में वक्त जाता है थोड़ा सा. सो कॉन्सेंट्रेशन ऑफ अ पर्टिकुलर सब्सटेंस इन द ट्यूबुलर फ्लूइड्स कैन इंक्रीज इन वन ऑफ द टू वेज. हाँ, ये इंपॉर्टेंट पार्ट है इसका. If the substance is secreted into the tubules, that's one way, or the other way is substance is reabsorbed but water is reabsorbed much more. Okay, तो क्या होगा, उस सब्सटेंस का कॉन्सेंट्रेशन जो है ट्यूबुलर फ्लूइड्स में वो बढ़ेगा, क्योंकि चलो वो रिएब्सॉर्ब हो रहा है, होगा थोड़ा सा, लेकिन वाटर उससे ज़्यादा रिएब्सॉर्ब होगा अगर उस किसी सेगमेंट में से, तो कॉन्सेंट्रेशन बढ़ेगा ना ट्यूबुलर फ्लूइड्स में. इस तरीके से वो होता है. और बाकी तो एक्सप्लेनेशन हम देख ही चुके हैं. नाउ दिस इज द एमसीक्यू विच वाज आस्क्ड ट्वाइस इन वेरियस INICETs, इसलिए आई थॉट आई विल जस्ट टेक इट. कैलकुलेट द टेटानाइजिंग फ्रीक्वेंसी फ्रॉम द ग्राफ दैट इज गिवन बिलो. तो चलिए पहले ग्राफ देख लेते हैं. ऑल राइट, ये एक सिंपल मसल कर्व का ग्राफ है जिसमें इन्होंने कॉन्ट्रैक्शन फॉलोड बाय रिलैक्सेशन, एक सिंगल कॉन्ट्रैक्शन फॉलोड बाय रिलैक्सेशन दिखाया है यहाँ पे. सबसे पहले व्हाट इज टिटानस सस्टेन्ड स्टेट ऑफ कॉन्ट्रैक्शन एंड फेलियर टू रिलैक्स दैट ऑकर्स फ्रॉम हाई फ्रीक्वेंसी स्टिमुलेशन. तो वो फ्रीक्वेंसी पूछी जा रही है जिस फ्रीक्वेंसी में स्टिमुलेट करने पर द मसल विल गो इनटू टिटानस. दैट्स कॉल्ड एज टिटानाइजिंग फ्रीक्वेंसी. Now, how to calculate titanizing frequency? Titanizing frequency is calculated as the reciprocal of the contraction period expressed in seconds. I repeat once again, and let's write it also. Okay, so titanizing frequency is expressed as, or is calculated as, 1 upon contraction period, reciprocal of the contraction period expressed in seconds. Contraction period is expressed in seconds. So what is left to us is to calculate the contraction period from this graph. Now you can see here how to read these graphs. At point A, stimulus was applied, then AB is the latent period, and then BC is the contraction period. Okay, BC is the contraction period, and then as the relaxation happens, the lever comes down. So CD is the relaxation period. So we know that the contraction period is this between B and C. Next thing is, how do we know how much is that contraction period? For that, they have given a time tracer and they have written 100 cycles per second, 100 CPS. This was a tuning fork with a frequency of 100 CPS. So these 100 cycles occur in 1 second. Okay, such 100 cycles will occur in 1 second. Which means, what is the duration of one cycle? 0.01 second. 1 upon 100 seconds. That is 0.01 seconds. Now, below the BC, you can see 3 cycles. If one cycle is 0.01 second, that means 3 cycles will be 0.03 seconds. So, now we know that the contraction period is 0.03 seconds from the graph that is given here. Titanizing frequency will be the reciprocal of that contraction period. So titannizing frequency will be 1 upon 0.03 seconds. That is 100 upon 3, and that will be 33 times per second. So the answer is 33 per second. If you stimulate this muscle 33 times in a second, it will go into tetanus. That is how you calculate or measure the titannizing frequency of a muscle from the graph that is given like this. Okay, but at least remember how to calculate titannizing frequency. Titannizing frequency is reciprocal of the contraction period, and contraction period is expressed in seconds. All right. Okay, so let's go to the next question now. I'm sure you must have seen this MCQ because it came twice or thrice in various INICETs, and therefore it must be there in some of the previous books or somewhere. Videos, books have mentioned it. So 33 times per second, and the explanation mentioned here. Okay, next MCQ is from the GIT. I expect some questions from GIT, at least one question from GIT this time. So least number of movements are seen in which part of the gut? Now basically there is something called as BER, basal electrical rhythm. The number of waves, electrical waves that occur per unit time, that is called as basal electrical rhythm. So that BER frequency determines how many times the contraction will occur in a particular segment of the digestive tract. So far as the BER is concerned, stomach has a BER frequency of 3 to 4 times per minute, basal electrical rhythm. And then duodenum, jejunum and ileum have the frequency of 12 per minute, 9 per minute and 7 per minute. Okay, so from duodenum to ileum this frequency goes decreasing, and that is why there is the law of the gut. Law of the gut is based on this information. That is, there is oral to anal direction of peristalsis normally. Why is that? It's because of this decreasing frequency from duodenum to ileum. All right. So that was. So what's the answer to this question? Least number of movements are seen in which part of the gut? Of course, the answer will be stomach, 3 to 4 times per minute. That's based on the frequency of BER. So I would expect you to read the motility of the stomach, motility of the small intestine in the fed state and in the fasting state, and the MMC, and what is the housekeeper of the gut, etc. Let's go to the next question. Which of the following will be present in the glomerular ultrafiltrate? Okay, it will be present definitely in the glomerular ultrafiltrate, and the options are: is it polycationic large radius molecule, polycationic small radius molecules, polyanionic large radius molecules, or polyanionic small radius molecules? Okay, this is fact based. This is not a very conceptual. We just have to know glomerular filtration barrier has negative charges. That is 𝐌𝐞𝐝 of the basement membrane of the glomerular capillaries, the endothelial cells. They have the basement membrane, and those basement membrane have 𝐌𝐞𝐝 with negative charges. So anions will be repelled and cations will be filtered out. Anions therefore are not readily filtered. Proteins are anions, so proteins will not get filtered out. And second, glomerular capillaries have fenestrae to allow passage of filtrates. So these fenestrae, the small opening, the small windows, they allow molecules with a certain diameter to pass, but larger molecules will not get filtered. Like proteins, again, proteins are relatively larger molecules. So polycationic small radius molecules will be easily filtered and will be found in the glomerular ultrafiltrate. Please remember, the glomerular capillary basement membrane has negative charges. So cations get easily filtered out. Okay, they get attracted towards the negative charges, and therefore they get filtered easily. And second one, size also will matter. Small diameters, the molecules with small diameter will be readily filtered out because of the size of those fenestrae. So that was very easy to answer. Let's take one more. We get such questions in the INICETs, match the following, or we get assertion and reasoning type of question. So match the following. This is about the action potential, various events in the action potential, and what is responsible for it. Depolarization, repolarization, after depolarization, and after hyperpolarization. So 4 events, and what is caused by, which event is caused by what ionic flux. Okay, depolarization, we know this. Sodium influx results in depolarization. Repolarization, potassium efflux by concentration gradient. So potassium goes out and repolarization starts. But then after depolarization, okay, here depolarization, this is caused by sodium influx, and repolarization by potassium exit. But this part is called as after depolarization. Slowdown of the repolarization is called as after depolarization. It's a misnomer. It's a misnomer. It is repolarization only, but it is called after depolarization. Why the repolarization rate has slowed? It's because potassium exit slows down. Initially it was rapid, so repolarization was rapid, but then potassium exit efflux will slow down later on, and therefore the rate of repolarization is slowing down. This part is called as after depolarization. You know why potassium exit slows down? Because of 2 reasons. See, initial concentration gradients, initial concentrations will be 145 on the inside and 4 on the outside. So potassium efflux will be rapid. There is a large concentration gradient. But then as the potassium goes out, 2 things happen. One is that the concentration gradient for potassium narrows, and plus potassium has gone out, so it carried positive charges to the outside, and those positive charges, they line up just on the outside of the membrane, creating an electrical gradient from outside to inside in the opposite direction, with more positive charges on the outside compared to just inside. So this is an opposing force for the potassium exit, and therefore net potassium exit slows down. That is shown as after depolarization. And then last part, after hyperpolarization, this is because excess potassium leaves. So excess positive charges leave and inside becomes excess negative, which is what is called as after hyperpolarization, or simply it's called as hyperpolarization. So that was a simple one, but I took it because I know very often that after first year, many students tend to forget all these things. So that was the MCQ. Please read the MCQs based on the, or MCQs or topic related to the action potential. I do expect one MCQ from action potential this year. Okay. Calculate, next MCQ. Calculate the respiratory quotient in a patient with the following data. Body weight 50 kgs, CO2 exhaled is 200 ml per minute, O2 consumed is 250 ml per minute. Now this is a simple one. respiratory quotient is equal to CO2 evolved per unit O2 consumed or per oxygen consumed. Respiratory quotient, let's make it little darker. Okay, respiratory quotient is equal to CO2 liberated or CO2 evolved upon O2 consumed. Okay, this is per unit time. So 200 ml upon 250 ml. How much will it be? It will be 0.8. Yes. So the answer in this case is 0.8. Simple question. You just had to know the formula. I have selected some of the formula based MCQs because I do expect them to be asked here this time. Okay. Give the sequence of the following events after the P wave on the ECG. So this type of questions are asked almost every year. So please prepare such questions based on the cardiac cycle and ECG correlation. ECG, cardiac cycle events and JVP, their correlation. These MCQs are they are being asked with unfailing regularity every year, regularly asked. So first of all, you need to understand that electrical events occur first and mechanical events occur later. That should be the first understanding. Electrical events means depolarization, repolarization. And those electrical events are getting recorded on the ECG. So ECG event will be the first to occur, and later as a result of that there will be systole, etc., the mechanical events. Okay, that's the first concept to be understood. So P wave on the ECG, it represents atrial depolarization, correct? And after that there will be atrial systole, and if you remember, atrial systole gets marked on the JVP as the A wave. So after P wave on the ECG, immediately what will come is the A wave on the in the JVP. A wave represents atrial systole. Yeah. So after atrial depolarization, there will be atrial systole. These are not very difficult MCQs, but very often the students find it difficult only because they have not taken this basic concept that there will be electrical event first, and as a result of that there will be mechanical event. Okay. Now, so after P wave on the ECG, the first event to occur will be A wave on the JVP, atrial systole. Okay. Then there will be QRS complex on the ECG, right? Ventricular depolarization. It will result in ventricular systole, and at the onset of ventricular systole, there is first heart sound. So next to happen will be that first heart sound. Okay. Then there will be ventricular repolarization on the ECG, T wave on the ECG, and then there will be ventricular relaxation. So we have atrial systole recorded as A wave on the JVP, then ventricular systole recorded as first heart sound on the phonocardiogram, and then electrical event in the ventricle, that is ventricular repolarization, and that will be followed by ventricular diastole and rapid filling of the ventricles. So in this case, the sequence of events will be A, B, D, C. Oh yes, answer is already, it can be seen here, no problem. But just remember this, electrical event first. So there will be event on the ECG, and it will be followed by mechanical event. And also to be remembered is atrial event first, ventricular event after that. The things will be easy. Okay. Next MCQ, which of the following is a transport through the cell membrane? Now, this requires small little concept. Okay, I can't see any messages still, so I don't know if you are asking any question or what's happening. I'll just check once again. No, can't see. Anyways, I hope that at least some people are watching and asking questions. You can ask the questions anytime, even in the end, and I will try to answer those questions. Okay, so which of the following is a transport through the cell membrane? Now, basically, the substances cross the membrane, right? And therefore, all transports are technically called as transports across the membrane because they're crossing the membrane. So, transport across the membrane. Good. But then some transports are the ones in which the substance goes through the membrane by invading the membrane. And in other cases, the substance crosses the membrane but without actually going through the membrane. Okay, and still it can go to the other side. So, endocytosis and exocytosis are the examples of transports across the membrane but not through the membrane. Okay, without invading the membrane, the substances cross. Examples, endo and exocytosis. So, clathrin-mediated endocytosis, pinocytosis, which is again a type of endocytosis, and constitutive exocytosis. These are all transports across but not through the membrane. So that leaves us with only one, solvent drag. Yes, and therefore that is the answer, solvent drag. Okay, I'm just trying to check whether the chat box is working or not. Anyways, so yeah, so that was transport through the membrane, solvent drag. It is opposite of osmosis, basically. What is osmosis? There is sodium and it pulls water. That is osmosis, movement of water because of the sodium. Solvent drag, which is also called as bulk flow, it is opposite, means water moves in bulk and it drags the sodium. See, osmosis was sodium is causing movement of water. Solvent drag means water is causing movement of sodium. Water is dragging the sodium. So whether it is osmosis or whether it is solvent drag, they are the transports through the semi-permeable membrane, okay, or through the membrane, and therefore this will be the answer. I would suggest for this exam, go through the general physio and particularly transport through the cell membrane very well, carefully, with its application like sodium potassium pump and digitalis, NCX, etc. Transporters, GLUTs, read them very well because one MCQ is always expected from those topics. Okay, let's take a next one. Which of the following increases in the COPD? Okay, now the thing that should be understood is in COPD, inspiration is easy, but expiration is difficult and laborious. That's the point number one. Why is it so? Look, in COPD, there is already airway narrowing and obstruction, and inspiration, the negative intrathoracic pressure, it pulls open the airways and inspiration becomes little easy. But during expiration, there is a positive pressure plus the recoil of the lungs. So the airways which are already compressed, they will be further compressed. Okay. Now that's point number one. And because of this, means as a fallout of this, there is increase in the residual volume. Point number two. Why? Because imagine that the person inspires 500 ml air. That was easy. But during exhalation, because of the early closure of the airways, all that 500 ml cannot be expired out. Some of that 500 ml will remain behind because airways got closed early. Okay. And because of that, the residual volume will go on increasing. Isn't it? Residual volume and therefore functional residual capacity, which includes residual volume, it will go on increasing. So in the given option, FRC is the answer. Residual volume was not there, but FRC is there, and that's the answer. Okay. FEV1. What happens to FEV1? Timed vital capacity. It decreases. Okay. It is the fraction of vital capacity that comes out by the end of 1 second of your expiration. Since the airways are narrowed, the amount of air coming out is less in COPD. And therefore, FEV1 decreases in COPD. Yeah. Normal value for FEV1 is 80 to 84%. That is 80 to 84% of the vital capacity should come out by the end of 1 second. That is FEV1. If it falls below 70%, it is the clear-cut sign of obstruction. Okay, so FEV1 decreases. Vital capacity, generally there is no change in the vital capacity. Option C. Vital capacity generally changes in restrictive diseases. In restrictive diseases, there is, let's say, restriction to the expansion of the lungs, and therefore the vital capacity will decrease. Remember, vital capacity requires your expansion of the lungs first, and then you expel out the air. So, in restrictive diseases, the vital capacity decreases. In obstructive diseases, the timed vital capacity decreases. That was a simple explanation. I'm sure this MCQ must have been very easy for you. Okay. Then 2 or 3 fact-based MCQs, so we'll go through them very fast. Which among the following leads to detachment of myosin head from actin? So this is about the cross-bridge cycling. Myosin head attaches to the thin filament, then creates the power stroke, and then the ATP binds with the myosin head so that that ATP is utilized. I mean that energy is utilized for detachment of the myosin head from the thin filament. Okay, so ATP binding to the myosin head will cause detachment of myosin head from the thin filament. So that was the answer. Attachment of the ATP to the myosin head, and myosin head using the ATP or the energy to detach itself from the thin filament. That was very factual. You may read the cross-bridge cycling. Another factual question. This was asked 2-3 years ago in one INICET. Counter current flow is seen in which of the following? Skin, kidney, testis, intestines. The answer is first 3. Skin, kidney, and testis. Each serves a different purpose. At each place, that purpose is different, but it shows counter current. Okay. For example, skin. Why there is counter current flow? For better heat transfer. In the kidney, why there is counter current flow? For concentrated urine formation. In the testes also, it is for thermoregulation that there is counter current flow. So these 3 places are the places where we see counter current flow. This was a factual one, nothing more to explain. And as I said, what purpose do they serve? You can add one more if you want. It is also seen in the dialyzer. counter current flow between dialysate and the blood. Okay, that's also a counter current flow. Intestines have unidirectional flow. That is, nutrients are absorbed and carried away. So it does not show counter current flow in the opposite directions. Okay, next question, identify the correctly matched pair. So transport processes and examples are shown. Which one is the correct one? Simple diffusion, oxygen; facilitated diffusion, calcium into sarcoplasmic reticulum; primary active transport, glucose and ion channels, O2. So obviously, first one is the correct one. Oxygen, its transport occurs by simple diffusion. So that's a correctly matched pair. Calcium pumped into the sarcoplasmic reticulum at the end of muscle contraction, and this brings about the muscle relaxation. It is brought about by SERCA, SERCA, and that SERCA is primary active transport. It's a calcium ATPase, SERCA. That's a calcium ATPase. It's a primary active transport. So that's a wrong pairing. Primary active transport, glucose, that's not correct. Glucose transport occurs actually in two ways: facilitated diffusion and secondary active transport. Secondary active transport will be seen in the GIT and kidney, and elsewhere it will be facilitated diffusion. तो ये भी सही नहीं है. And ion channels, oxygen does not have ion channels. It occurs by simple diffusion through the lipid bilayer. So again, the only correct match was A, and that's the answer. So as I said, just check this topic before you go to the exam. If you are revising physiology, transport processes, transport proteins is the topic to watch out for. Let's go through some MCQs quickly, because I have to, in the end, I'm going to discuss more of a equation based or concept based. So let's see some of these MCQs first. Which of the following is not a cause of central cyanosis? And the answer is hypothermia. You know, hypothermia in extreme cold weather, you see that the nail beds are sometimes bluish. It's called peripheral cyanosis. What happens is, because of that extreme cold, there is peripheral vasoconstriction. Okay, so new blood cannot come in properly, and whatever oxygen was delivered, that oxygen was already taken up by the tissue. Okay, removed by the tissue, and therefore the reduced hemoglobin level, methemoglobin level, its level increases locally. Okay, and that gives a blue color cyanosis, that is called as peripheral cyanosis. All other causes are called as central cyanosis. They are central cyanosis. Hypothermia, peripheral cyanosis. The reason is peripheral. Okay, match the following transporters with the molecule that they carry. So again, a factual. Hemopexin carries heme. Haptoglobin carries hemoglobin. Prealbumin carries thyroxine. And one more, there is albumin. Bilirubin binds with albumin. This was simple. So just take it as a factual information. Hemopexin carries heme. Haptoglobin combines with hemoglobin. Hemoglobin is normally inside the RBCs. But when there is widespread destruction of RBCs and hemoglobin comes into the plasma, then it is combined with haptoglobin. Prealbumin and thyroxine. We know this already. That is thyroxine binds with TBG, that is thyroxine binding globulin, TBPA, thyroxine binding prealbumin, and also albumin. And bilirubin and albumin, that was there. Okay. Next, what will happen to the alveolar ventilation when pH is changed from 7.4 to 7.3 at the PaO2 of 100 mm of Hg? So one thing is clear, that PO2 is 100. That means this is not hypoxia. And they have changed the pH from 7.4 to 7.3, means on the acidic side. Acids are being produced. All right. And the arterial H plus, metabolic acids and arterial H plus, they are sensed by peripheral chemoreceptors, carotid bodies and aortic bodies. And that will stimulate the breathing. So if the breathing is stimulated, respiratory minute ventilation will increase and alveolar ventilation will also increase. That was a fairly simple one. So answer is increased ventilation. And I told you the reason why. pH has decreased, that means H plus, acids are being produced, and acids arterial H plus is sensed by the peripheral chemoreceptors and that stimulates the ventilation. Okay. Next, identify A and B. Now this is some membrane protein and you can see that there are 5 binding sites. So obviously this is going to be sodium potassium pump. It has got 5 binding sites. 3 on the inner aspect, 2 on the outer aspect. So on the inner aspect there is sodium binding site, ATP binding site and phosphorylation site. And on the outer aspect there is potassium binding site and ouabane binding site. So A and B are sodium binding site and the potassium binding site. Do we have that in the options? Yes, sodium and potassium, A and B. So that was the answer. We had to just identify the structure. Okay, since this is a membrane protein with 5 binding sites, immediately it should strike to us that this is sodium potassium pump. And of course, what was another hint? ATP has been shown to bind. So this must be ATPase. Okay. Which of the following acts by increasing the phospholipase C? So this will require some explanation. Let's explain this. Look, there is G protein coupled receptor. In the membrane, there is G protein coupled receptor, right? Okay. Now, there is a G protein basically with 3 subunits, alpha, beta, gamma. And there is a receptor which is coupled to it. It's also called as serpentine receptor. It has got 7 transmembrane segments. So this is a G protein. This is the G protein coupled receptor. Now, this G protein has alpha subunit, which is going to be the catalytic subunit. Okay. What I'm trying to say is, when the hormone comes and binds with the receptor, the alpha subunit will dissociate from the other 2 subunits. And it will move along the membrane. And it will activate an effector protein inside the cell. What is that effector protein? See, if the alpha subunit is GS alpha, G stimulatory alpha, then it will stimulate the adenylyl cyclase enzyme and that will convert cellular ATP into cyclic AMP. So increased production of cyclic AMP and then the effects will be seen. If the subunit is GI alpha, G protein, alpha subunit and I, that is inhibitory. In that case, it will inhibit the adenylyl cyclase and the cyclic AMP levels will decrease. This happens in certain conditions. Particularly, this mechanism, decrease of cyclic AMP, is seen in the case of catecholamines action. Please remember this. And there is another subunit which is GQ alpha. Alpha subunit has GQ alpha. Now this time it is not going to act via adenylyl cyclase. When there is GQ alpha subunit is present, it then activates not adenylyl cyclase but activates phospholipase C. Okay, and as a result of that activation of phospholipase C, there will be production of second messengers which are phosphatidyl inositol biphosphate and diacyl glycerol. And then the effects will be seen for that particular hormone. Now, which hormone works like this? By activating this subunit. Commonly known hormone is GnRH. GnRH has this pathway. But otherwise, many of the protein or peptide hormones, they act via GS alpha, and that increases the cyclic AMP inside the cell. So that was the explanation. GnRH action is via GQ alpha. All right. Two vessels, one with a diameter of D and length L, another with a diameter of 2D and length 2L. Flow in the second one will be how many times that of the first one. So if the length was doubled and diameter was doubled, what will be the change in the flow? That was the question. It's 8 times. Let's see how. Flow is directly proportional to the 4th power of the radius, and it is inversely related to the length. Okay. So if the radius or diameter was doubled, flow will be increased by 2 raised to 4, that is 16 times. And length was doubled, so flow will be reduced by half. Okay, because it is inversely proportional. And therefore, final outcome will be 16 times increase, but reduced by half. So 16 upon 2, flow will finally increase by 8 times. Alright, so just remember 4th power law, because MCQs have been repeatedly asked on that. 4th power law of the radius. Radius was doubled, flow is increased by 2 raised to 4. Okay, next one. Use of transcutaneous nerve stimulation to relieve pain is an example of. So TENS, transcutaneous electrical nerve stimulation, TENS, is an example of what? It is an example of gate control pathway of pain. Lots of MCQs have been asked on gate control pathway. So let me just quickly tell you about it. Because twice or thrice this MCQ has been asked, where they ask you, there is a football player and that football player got injured, his knee was hurting, he rubbed his thigh and the pain was relieved for some time. So what was working? Or in 1 year they had asked this MCQ. They gave a diagram actually, and the same MCQ, that is, football player got injured at the knee, then he was rubbing the thigh and the pain was relieved, knee pain was relieved for some time. So what was the site of action? And in that MCQ they gave 4 sites: A, B, C or D. And the answer is A. How? Let's check out. Gate control pathway of pain. How does it work? Let's quickly understand. First of all, what is the gate for pain transmission? Substantia gelatinosa in the spinal cord. Where is it exactly located? Laminate 2 and 3 in the dorsal horn. So lamina 1 gone, that is lamina marginalis. Then lamina 2 and 3 is called as gone means that's the lamina 1. We are interested in lamina 2 and 3, that is called as substantia gelatinosa or substantia gelatinosa of Rolando, and that is where gate for pain transmission is said to be present. So let's say here is a pain carrying fiber. Okay, it ends here and second neuron then crosses the midline and ascends upward in the lateral white column. And another fiber which is pressure carrying fiber. So if you apply pressure on this, it enters the spinal cord and bilateral inhibition, it will inhibit the pain signals in this pain carrying fiber. So gate will be closed in the substantia gelatinosa. That is how the gate control theory works. And so that was the answer. Gate control theory. Gate is in the substantia gelatinosa. TENS, that is transcutaneous electrical nerve stimulation, TENS. This is where you stimulate the nerve, transcutaneous nerve stimulation, and it works on the same principle, gate control pathway of pain. So that was the MCQ. They had given these 4 options. 1, 2, 3, and 4 was anterior motor neuron. So the answer was this one. Dorsal horn, laminate 2 and 3. Okay, let's check out the next one. So this is how the MCQs have been asked in the previous years. Yeah, this is the explanation. Okay, wrong statement among the following about the accommodation changes in high altitude ascent. Now, high altitude ascent means hypoxia. The person is facing hypoxia. So which of the following will not occur in hypoxia? That's the question. Now look, hypoxia, so C is very obvious. Hypoxia is occurring. You know, hypoxia causes vasoconstriction in the lungs. So pulmonary vasoconstriction is also there. And hypoxia stimulates breathing. And if the breathing is stimulated, ventilation is stimulated, CO2 will be washed out of the body. And if remember, CO2 means acids. CO2 combines with water to form H+. So if CO2 is washed out, means acids are washed out. H+ is washed out. And if H+ is washed out, it means it is alkalosis. Result will be alkalosis. So respiratory alkalosis will also be there. In fact, because of this possible respiratory alkalosis, carbonic anhydrase inhibitors, acetazolamide, is given before the ascent to tackle this. So B, C and D definitely will occur at high altitude ascent. Metabolic acidosis will not occur. Certainly not acidosis, it will be alkalosis, respiratory alkalosis. So that's the answer. Okay, let's just quickly go through the remaining MCQs and I'll tell you how to solve those MCQs and what you should read. For a 4-year-old child weighing 15 kgs with serum creatinine 1 milligram per deciliter and serum urea 100 milligram per deciliter, what is the closest approximate to GFR? What is the GFR in this individual? Can you tell me what are you going to use to calculate the GFR in this? Cockcroft and Gault formula. Yes, Cockcroft and Gault formula was to be used. So from the data, you must understand what should be used to solve such MCQ. Cockcroft and Gault formula for creatinine clearance. It says creatinine clearance is equal to 140 minus age into body weight divided by 72 into plasma creatinine. So they have given the values over here. Put the values in the equation and you get the answer. The answer is 33 ml per minute. That was the GFR. Okay. Next, which of the following is a postsynaptic event? Norepinephrine action on alpha-2 receptor. This is a presynaptic event. You know, norepinephrine, alpha-2 receptor of norepinephrine is present in the presynaptic neuronal membrane. Okay. And what is the job of this receptor? To decrease the further release of norepinephrine from that neuron. So, feedback inhibition. But definitely this is a presynaptic event. Then post-tetanic potentiation in the cortical neurons. You know what is post-tetanic potentiation? Repeated stimulation of a synapse for some time at high frequency, tetanically. Then for some time, the transmission is enhanced. That's called as post-tetanic potentiation. And why does that happen? because of a high frequency discharge in that synapse, calcium came in the presynaptic neuron, and calcium accumulates in the presynaptic neuron for some time. And more the amount of calcium, greater will be the neurotransmitter release, and that is how the transmission is potentiated. So this is a presynaptic event. Sensitization to a life-threatening event. This is also presynaptic, extra release of neurotransmitter from the presynaptic neuron whenever we face such life-threatening or important events. This is called as sensitization. So the only postsynaptic event is LTP, long-term potentiation in hippocampus. This is shown by the NMDA receptor of glutamate in the hippocampus, and this is the basis for long-term memory. All right. Next, yes, we will take one more MCQ. Two scenarios of muscle contraction are shown in the diagram below. Select the correct statement regarding these scenarios. This MCQ came twice, so I have just selected it so that I could explain what this MCQ is about. If you can see the diagram, in scenario A, load is at here. This is the resting condition of the muscle, and from this happens. In scenario B, this is the resting condition and load was applied, and from this happens. This is what was given to us, and they are asking what exactly is happening here. Scenario is A is preload, scenario B is afterload, or work is done in A but not in B. A is isometric contraction, B is isotonic contraction, or more heat will be liberated during A. Answer is A. That is, scenario A is preload and scenario B is afterload. Why? Because you can see here, this is the resting condition of the muscle, load was applied, and this is what happened to the muscle after load was applied. What do you see here? The muscle was stretched after application of load. Muscle was unsupported. So when the load was applied, the muscle got immediately stretched. Okay. It got stretched in its resting condition. That means the load started acting on the muscle even before its contraction started, in its resting condition only. So obviously this is preload. Okay. And in the scenario B, it's afterload. See, muscle was resting, load was applied, and then this led to this. That means the muscle has contracted and shortened, and it also displaced the load, as you can see. So, but load was displaced by the muscle contraction. Load started acting on the muscle after the contraction started. So that is afterload. And just remember one more thing here. That is scenario B, the work is done only in B but not in A. See, muscle contracted and actively displaced the load. Work done is load into displacement. So load was displaced by active muscle contraction, and therefore work was done by muscle only in B but not in A. Many students asked me this last time after this came in exam, that sir, even here the load was done, because load even in scenario A work was done because load has moved through some distance. No. Simple thing to be understood is, when muscle contracts and it displaces the load, that is the work done by the muscle. Here, simply speaking, load has stretched the muscle and therefore load moved. Muscle did not perform any work, okay, in scenario A. So these small concepts are important to solve such MCQs. Okay, next. A syrinx is growing in the central canal of the spinal cord. First sensation to be affected or lost will be temperature or vibration or fine touch or proprioception. You know, in syringomyelia, there is a syrinx, cyst-filled lesion in the central canal of the spinal cord, and it starts growing anteriorly. So the fibers that it will attack will be the anterior commissural fibers. They are the fibers that eventually form the lateral spinothalamic tract, anterior commissural fibers. And what is the sensation carried by them? Pain and temperature. So temperature will be the sensation affected by the syringomyelia. Okay. So let's take only one or two more MCQs, and then you can go to study your own. In the venous blood, mean corpuscular volume is it same as elsewhere, or greater than elsewhere, or lower than elsewhere, or variable? It is greater than elsewhere. Why? Because in the capillary blood, there is chloride shift. Carbon dioxide enters the RBCs and it combines with water to form H2CO3. It splits into H plus and HCO3 minus, and then HCO3 minus goes out and chloride comes in. This is what happens in the tissue, in the capillary blood, and this blood will now go to the venous side. Now chloride has entered the RBC, and chloride is osmotically active. So it will pull some water inside the RBCs, and the RBC volume will increase slightly. So in the venous blood, mean corpuscular volume is slightly greater as compared to elsewhere in the body. An ORS that contains glucose was administered to a dehydrated patient. Which of the following transporters are involved in the glucose absorption from the gut? If the ORS contained glucose, how this glucose was absorbed? Answer is SGLT1 and GLUT2. So let's check it out. How glucose is absorbed from the GIT. This was a simple one and it has been asked multiple times. Here is a GI lining. So glucose in the digestive lumen has to enter the blood vessel. That means it has to cross two membranes. From the lumen, it has to enter the cell, and from the basolateral side, it has to leave the cell to enter the blood vessel. On the apical membrane, which is facing the lumen, there is SGLT1, by which glucose will enter. And on the basolateral side, there is GLUT2, which causes glucose to exit the cell and enter the blood. Okay. Always remember one point. GLUT2 is used by the glucose to leave the cell, any cell. This cell or muscle or liver cell after glycogenolysis. Glycogenolysis increases the glucose inside the cell so that it can come out and it can enter the blood vessel. So even there it will use GLUT2. GLUT2 to leave the cell. So SGLT1 and GLUT2 are utilized by glucose for absorption from the GIT. All right. Any other MCQ left to discuss? Okay. This is the last one, but an interesting one. Which of the following can be described as feedback feed-forward type homeostatic regulation? Means it should first have feedback and it should also have feed-forward. Homeothermy or hemostasis or calcium homeostasis or increase in heart rate, respiratory rate with muscular exercise. So what say? What is your answer on this? The answer is homeothermy. Yes. Wondering how it is like this, and what about the other options? Check it out. See, let's take an example. What is homeothermy? Body temperature regulation. Okay. We have two types of temperatures for our body. The shell temperature or surface temperature and the core temperature, which is the tissue temperature. Okay. Tissue temperature has to be kept constant under all circumstances. Otherwise, the cells will not be able to perform their function. Okay. But shell temperature keeps on changing. Now see how the homeothermy occurs. Suppose we enter the cold environment. Okay. Now, because of that, the skin temperature will drop and the blood temperature begins to drop. Now, this blood goes to the hypothalamus. Hypothalamic thermostat will sense it and then it will cause shivering. So the temperature that had dropped, blood temperature that decreased, was brought back to normal. That was a feedback, negative feedback. But the tissue temperature or the core temperature, which could also have dropped because blood temperature has decreased, so it would have led to drop of tissue temperature also, that was prevented even before it could occur. So regulation of, maintaining the tissue temperature will be feed forward. Before it could occur, the corrective action was taken by the hypothalamus and shivering was induced. So shell temperature and temperature of blood got corrected by negative feedback, that is feedback, but tissue temperature was preserved even before it could change. Corrective action was taken by the shivering. So it means it was feed forward. And therefore this is an example of feedback, feed forward. Hemostasis, it's an example of positive feedback, negative feedback, the combination. You know how? See, if there is injury to a blood vessel, there is hemostasis, means stoppage of blood. Let's say platelet plug formation occurs. That's an example of positive feedback. It stops the bleeding. So first positive feedback occurred, correct? Then as a result of that, as a result of injury and bleeding, blood volume had slightly decreased. Then next, over a period of time, that blood volume will be rectified. So that will be negative feedback, no? Injury caused some bleeding, blood volume had decreased. Then first the platelet plug formation occurred, bleeding stopped. And then the next step would be to restore the blood volume, which had decreased after bleeding. So positive feedback, platelet plug formation, and then the negative feedback, restoration of blood volume. So this is combination of positive and negative feedback, hemostasis. Calcium homeostasis, negative feedback, out and out. And increase in heart rate and respiratory rate with muscular isotonic exercise. This is feed forward feedback. The question was feedback, feed forward. How? Let me explain. See, heart rate and respiratory rate increases just at the onset of exercise. This is feed forward. In anticipation that the muscles will demand extra oxygen, heart rate and respiratory rate increases just at the start of exercise. So this is in anticipation, and therefore this is feed forward. During the course of exercise also, the heart rate and respiratory rate continues to increase. That is negative feedback. As your exercise continued for 4 minutes, 5 minutes, 6 minutes, carbon dioxide was generated more, and that carbon dioxide is to be thrown out of the body, normalized. So by increase HR and RR, heart rate and respiratory rate, that carbon dioxide will be thrown out of the body, normalized. So that is negative feedback. So this is an example of feed forward followed by feedback. The question was feedback followed by feed forward, and the answer was temperature regulation. So please read all these topics. Clearly the questions are expected from these topics. Particularly cardiac cycle and LV-PV loops are expected this time. So just go through them, and that will be all. All the best for your exam. Do well. Take your time to read the MCQs, but don't jump on the options for immediately. Wait, think about the answer and then have a look at the options. Try to regularize your circadian rhythm in the coming week, and I'm sure you will do well in the exam. All the best. Thank you. Bye-bye.